For this portion of the video presentation for Module 7, I'm going to be discussing problems with the thyroid gland. It's important to go back and review some anatomy of the thyroid gland before proceeding. Just remember that the thyroid gland is a gland that sits over the cricoid area on the neck. It's sort of, it's like a butterfly-shaped gland that sits on the anterior surface of the cricoid of the trachea. And it's important to note that the parathyroid glands are a piece of this, and they essentially are four little glands that sit on the posterior surface of the thyroid gland. Make sure that you review the hormones that are secreted by the thyroid and the parathyroid gland. The thyroid gland secretes T3 and T4, which of course regulates the thyroid hormone levels. And that, if you recall, regulates the patient's metabolism. It's very important for heat regulation as well. The thyroid gland also secretes calcitonin, and if you recall, we talked about this as far as the calcium levels in osteoporosis. Calcitonin regulates calcium levels, and it decreases serum calcium levels, so that means it decreases the blood levels of calcium, and it does this by decreasing the bone resorption, which, if you recall, is the breakdown of the bone. It's important to understand that the parathyroid gland works in opposite of this. So it's the parathyroid and the calcitonin that work together to regulate the serum calcium levels. So the parathyroid gland main purpose is to regulate calcium and phosphorus metabolism. And what it does is it increases bone resorption, so it works in opposition of the calcitonin. So it's important to understand that these two, thyroid and the parathyroid, have an important role in the regulation of calcium levels in the body. The other thing that is to take note of is, if you look back, the hypothalamus actually secretes something called a thyroid releasing hormone. And then if you look back at the anterior pituitary, it releases something called the thyroid stimulating hormone. These all play a part in whether you have normal thyroid levels. So it's just important to note that it could be something where someone's thyroid is functioning properly, but if the pituitary is not and not releasing the thyroid stimulating hormone, then that could be a problem as well. So the problem could originate elsewhere besides the thyroid gland, and that's just because it is stimulated by hormones that are secreted in another gland. Hyperthyroidism is a hypermetabolic state that the excess of the thyroid hormone creates. So, and just kind of looking at the big picture here, the thyroid hormone controls metabolism, or it balances metabolism of the patient. So excess of this hormone will cause a hypermetabolic state, so an increased metabolism. Your patient will show signs and symptoms of a hypermetabolic state. These signs and symptoms can be seen on page 1394, chart 66-1. It is a nice chart that kind of summarizes the signs and symptoms of hyperthyroidism. This is somebody that's going to be very thin because of their increased metabolic state. In contrast to that, when you think about hypothyroidism, which is a deficiency in the thyroid hormone, they're going to have signs and symptoms of a hypometabolic state. So it's just important to kind of keep that in mind as you think about the differences between hyper and hypothyroidism. There are several different causes for hyperthyroidism. The first one is something called Graves' disease. It is thought to be autoimmune, and basically there is a response to an antibody that causes a response from the thyroid gland. It increases the number and size of cells, which begins to enlarge the thyroid gland, and it forms something called a goiter, and it overproduces the thyroid hormone, which is something called thyroid toxicosis. Another cause for hyperthyroidism is something called a toxic multinodular goiter. And basically, it's just where the thyroid has some enlarged tissue, or potentially a benign tumor that causes an enlarged thyroid and an overproduction of the thyroid hormones. It's a little bit milder signs and symptoms than Graves' disease, and the patient does not have a lot of the more obvious symptoms of hyperthyroidism. Graves' disease causes something called exophthalmos, and we'll talk about that a little bit. We have a picture here. It's those protruding eyes, the big kind of bug-out eyes. And then the pretibial mixed edema is something that is caused by Graves' disease as well. And the patient that has the multinodular goiter does not have these extreme symptoms. So that's the big difference between those. So the third cause for hyperthyroidism can actually be something that we can cause if we're trying to treat a hypothyroidism. It's called an exogenous cause. So basically what happens is if somebody is hypothyroid, we give them something called levothyroxine or Synthroid, and sometimes we can give them too much, and it creates a hyperthyroidism. So that one's easily treatable, but that's the third cause for hyperthyroidism. So this is just taking a little bit closer look at hyperthyroidism caused by Graves' disease, which we said is an autoimmune disorder that causes a goiter because of the edematous thyroid gland, and that is just where somebody you're going to be able to palpate their thyroid. You're going to be able to see an enlarged thyroid very obviously if they have a goiter. This is typically diagnosed in women between 20 and 40 years of age. It is found to be related to other autoimmune disorders. If somebody has diabetes, if they have rheumatoid arthritis, they have a tendency to have Graves' disease as well. And I kind of mentioned the exophthalmos, and I think I have a picture here on the slides of just the enlarged eyes. I think probably one of the most famous people that has the exophthalmos related to Graves' disease is Barbara Bush. When her husband was in office, she was treated for this. Pretibial mixed edema is a dry, waxy swelling of the front of the lower legs. That's a pretty big indicator of Graves' disease as well. I want to point out a table on page 1395. It's table 66-1. It's talking about goiter classification. So it's basically, there's levels. So 0 would be that it's not palpable, and that's normal. You should not be able to palpate the thyroid gland in most patients. And then it goes to number 1. If you can't really see a mass, but you can palpate it. And then a level 2 would be, or a grade 2 would be that you could see it and that it's palpated. So just kind of review that to see how it would be documented if someone has a goiter or not. Hyperthyroidism can cause cardiovascular problems as well. It can cause increased blood pressure, tachycardia, dysrhythmias. A lot of times if somebody has a goiter related to Graves' disease, they will check for bruits near the thyroid gland, near the goiter, just because this increased blood flow to the area will cause bruits. And if you remember, that's where you can hear the swish, swish sound over that area. We've pretty much already covered these two. Just like I said, the toxic multinodular goiter is a milder form of hyperthyroidism, and it's usually just multiple thyroid nodules, and they're typically benign. It could be like a little benign tumor on there. The patient is going to have not as excessive signs and symptoms of hyperthyroidism with a toxic multinodular goiter. And then the exogenous hyperthyroidism is just the excessive use of the thyroid hormone replacement, and that would be treated very easily by just decreasing the dose of the levothyroxine that the patient is having. Here's the picture of the patient with exophthalmos, which is the bug eye, the protruding eyes, and that is typically seen with Graves' disease. This is typically caused by the edema and the extraocular muscles and increased fatty tissue behind the eye kind of pushes the eyeball forward. This can cause pressure on the optic nerve, which can impair their vision. They can also have something called photophobia, which is sensitivity to light. This can create dry eyes, and it can damage the cornea if the patient's unable to completely close their eyes. So this actually can cause some pretty extensive damage to their eyes if it's not treated properly. This is a patient with an obvious goiter that can be observed. Again, we kind of talked about the ways to assess a patient for an enlarged thyroid gland. A lot of times you can come up behind them and put your hands and palpate it. And then if you have them swallow a drink of water, you can feel it. When they swallow, you can feel the protrusion of the thyroid gland, which you typically should not be able to feel. A few other symptoms with hyperthyroidism, they might have fine, soft, silky hair, warm, moist skin. Again, it's all signs and symptoms of a hypermetabolic state. So they might have excessive movements for tremors. They may appear restless, irritable, or tired. And then there's a psychosocial piece of this as well. Their emotions might be kind of inappropriate. They might be crying a lot or laughing inappropriately. And basically, they'll have just kind of report a change in their mental or emotional status. For the laboratory assessment and diagnostic tests, if you go to page 1396, chart 66.2 has a wonderful chart about all the different labs that are done to diagnose hyperthyroidism or hypothyroidism. Remember, we have to look at thyroid levels beyond just the T3 and T4 because that can help us establish the cause. There's also a blood test that we can do for the thyroid antibodies, and that is to determine whether somebody has Graves' disease. So you want to see if they've had these built-up antibodies that's indicative of an autoimmune disorder, which would mean Graves' disease. The TSH level is very, very important in determining where the cause is coming from. It's a little bit more indicative of hypothyroidism, and we'll talk about that when we talk about secondary and primary hypothyroidism, but it's a very important test that goes right along with the T3, T4 level. Thyroid scan is something that we can do to just evaluate the size and the functioning of the thyroid gland. The thyroid scan involves the use of radioactive iodine. The patient will take the iodine by mouth, and then they measure how much of the iodine is taken up by the thyroid gland in a 24-hour period. Normal is 5 to 35% of the dose is taken up by the thyroid gland in a 24-hour period. If this is increased, if this is above 35%, then the patient has hyperthyroidism. Then the prep for a thyroid scan would require that you ask the patient some questions about whether they've had any other tests recently with any kind of an iodine dye. If they have to wait 4 weeks after that test. Or if they're taking any kind of medicine or any kind of drugs that contains iodine, it should be discontinued for a week before the scan. Ultrasound is a pretty easy, non-invasive test that they can do, and it basically just looks at the general size, and it can determine if there's any nodules or masses on the patient. And it's a pretty quick, painless test. Electrocardiography is basically a test that just determines if somebody is tachycardic, if they're having any dysrhythmias or any changes in their EKG that could indicate that they have a hyperthyroid problem. I know a couple of people that actually that's how they were diagnosed. They were complaining that they were having palpitations and that their heart was racing, and that was their biggest complaint. And in a series of tests, they were determined that they were hyperthyroid, and that was the cause of their tachycardia. Treatment for hyperthyroidism, if we're talking about non-surgical management first, of course, we're typically always going to try to do the most non-invasive treatment first. Basically, monitoring is going to involve just monitoring the patient's vital signs, heart rate, things like that to make sure that they're controlled. And if a patient has an elevated temperature, that can indicate that the patient is actually going into a condition called a thyroid storm. That is a life-threatening event, and that's with an uncontrolled hyperthyroidism. It's characterized by a high fever and severe high blood pressure. Basically, when I've seen this occur is when someone is basically not under medical treatment and they've just been undiagnosed as having hyperthyroidism. It's very important that they do get diagnosed and treated, because it actually can lead to a life-threatening situation if they're not. So along with monitoring is just promoting comfort, reducing stimulation. So again, this patient is in a very hypermetabolic state. They need to chill. They need to relax. And it's just, reducing room temperature, decreasing distractions, keep the environment quiet, decrease stimulation, things like that. Drug therapy, we're going to go into some antithyroid drugs to look at some things that we can do to treat hyperthyroidism. Drug therapy and radioactive iodine therapy are now the most common treatments for hyperthyroidism. The drug therapy, basically what they do is some of them decrease the uptake of iodine, which decreases the production of thyroid hormones. All of these drugs are listed in Chapter 66 on page 1398 in Chart 66.3. These drugs mostly are pretty effective for the treatment of hyperthyroidism. The problem is there are a lot of black box warnings, which means that there's a lot of pretty serious side effects. A lot of it is about liver damage. They can cause a lot of liver injury or liver failure. Methimazole can cause birth defects, so there's a lot of patient teaching that would be involved in these medications, a lot of precautions that need to be taken. Other drugs that can be used in the treatment of hyperthyroidism is something called beta-adrenergic blocking drugs. Propranolol, Inderal, Coreg is one of them, metoprolol is another one. But basically they're kind of supportive therapy, and they, if you look back at the beta receptors, there's beta receptors in the heart, which responds to epinephrine and norepinephrine, which is related to our metabolic state and our sympathetic nervous system. These blocking agents block the heart responding to all of this going on, so it can treat the tachycardia and the palpitations. So that's why they're a supportive therapy. So radioactive iodine therapy is a pretty common treatment for hyperthyroidism. It cannot be used in pregnant women. That's pretty important to remember. So they would have to rule out pregnancy before they were able to use this treatment. But basically, the thyroid gland picks up this radioactive iodine, and it can destroy the cells that are causing the increased levels of the thyroid hormone. The number of treatments depends on the patient. This is done on an outpatient basis. Sometimes they'll need to have more than one treatment, and that's due to the fact that you have thyroid stores in the body. So they'll have to wait and make sure that all the stores have been depleted. This is a radioactive therapy, so the patient does have to take precautions because of the radiation. So they can cause a radiation exposure to people that are around them, so they'll have to prevent exposure. There's a chart on page 1398 at 66.4. It talks about all the education that you should give someone getting radioactive therapy for the hyperthyroidism. A lot of it's sort of similar to like chemo precautions, basically. You don't want to be exposed to any of their bodily waste, and they need to avoid contact with pregnant women. So just make sure you review that chart to see the treatment, the precautions that need to be taken with that kind of a treatment. So it's just a sort of a summary for the medication treatment for hyperthyroidism. These are all listed again on page 1398. And you can just kind of look, they're listed out individually and how they work to treat hyperthyroidism, and then the big thing is the patient teaching, of course, of what they need to do while they're taking these drugs. So make sure you review each one of those. A lot of it is, a lot of these, if it's, hyperthyroidism occurs more often in women ages 20 to 40, so a pregnancy issue is something that they have to really be careful about. There are some patients that the treatment with drug therapy and radioactive iodine is not effective. They might have to remove their thyroid gland, and this is a partial or total removal of the thyroid gland. The important thing to understand is if we remove their thyroid gland, everybody still needs some degree of a thyroid hormone. So these patients, if they lose their thyroid gland, or typically part of it, then they are going to have to be on thyroid treatment, thyroid hormone supplements for the rest of their life. This is a lifelong treatment because they no longer have a thyroid gland that makes that thyroid hormone that we all need to keep our metabolism normal. So a patient that has been scheduled for surgery, if you remember back to when we were talking about the anatomy of a thyroid gland, the thyroid is highly vascular. And the more it's enlarged and swollen, the more vascular it is. That means that it has a more risk for bleeding. So a lot of times before they do surgery, they try to give them radioactive iodine. They try to give them meds to decrease the size of the thyroid before they go in and take it out. That way it decreases the risk for surgery. All of their tachycardias and dysrhythmias need to be controlled with beta blockers like we talked about. Their hypertension needs to get under control before they take this patient into surgery. And of course, they're going to have the typical pre-op teaching and post-op teaching of any other surgery patient. The thing that isn't important to remember with a thyroidectomy is that because it is a highly vascular area, it is in kind of a important area. It's near the cricoid, which is your trachea, which is your airway. So post-operatively, it's very important to monitor for bleeding and blockage of the airway. It's important to note that typically, even if they do a total thyroidectomy, they try to leave the parathyroid glands behind. If they do a subtotal thyroidectomy, they will leave partial thyroid tissue and they suture it to the trachea. Post-operatively, like I said, monitoring them for complications is very important because of the nature of the surgery. This is in the PACU, which is the post-anesthesia unit. They're going to monitor them very closely with vital signs very often, and just monitor for signs of bleeding and make sure their airway is maintained. They have to be elevated with sandbags and pillows to support the head and neck. The patient will be in a semi-Fowler's position. And you always want to make sure that you decrease the tension on the suture line around the neck. So no neck extension, which could cause tension on those sutures. Because of the vascularity of the thyroid, hemorrhage can occur. When the patient is more at risk is in the first 24 hours post-op of hemorrhage. So for the first 24 hours, that patient's going to be monitored very, very, very closely for any kind of bleeding. You're going to monitor the dressing, of course, and then always make sure, that bleeding can go back behind the patient. So you always want to make sure you kind of look behind their neck as well to make sure there's no bleeding occurring. And always, that means monitoring their blood pressure, all their vital signs to see any signs and symptoms of any kind of bleeding. And of course, you know how to assess for respiratory distress. If somebody's oxygen levels are decreasing, if you see difficulty with breathing, if you hear stridor, which is a high-pitched wheezing, if you hear any kind of abnormal breath sounds, if you're having to turn up their oxygen, you need to assess them to make sure that their airway is not closing. The other thing to remember is that the thyroid and the parathyroid hormones help to regulate calcium levels. So like I said, they try to leave the parathyroid hormones intact, but sometimes post-surgery they may not be working normally, or there may be some damage to them during the surgery. So you have to monitor them for low calcium levels, which would be hypocalcemia. The signs and symptoms of that are muscle twitching, tingling around the mouth, or toes and fingers. If they're complaining of that, those are questions that you're going to be asking them. And then also to make sure they may have to administer calcium chloride or calcium gluconate in the event that the calcium levels become extremely low. Again, due to the anatomy of where this surgery occurs, you have to assess for laryngeal nerve damage, which you would assess by checking for hoarseness or the ability to speak. So every couple of hours, you're going to make sure that the patient is not losing their voice, not able to speak, things like that. And then again, just want to mention the thyroid storm, which can occur. It's not, the risk isn't really high, but there are some incidences of a thyroid storm, and that's basically related to just the manipulation of the thyroid gland from the surgery. So just making sure that they don't have the signs and symptoms of a thyroid storm. And what that is like a very acute excess of the thyroid hormone. This is what it needs to be remembered. The key manifestations of thyroid storm include a fever, tachycardia, and systolic hypertension. So if you think about systolic, that means your top number is hugely increased. So those are the three manifestations of somebody that's looking like they're going into a thyroid storm, and you need to notify the provider immediately so that it can be treated, because it's such a hypermetabolic state that it can cause life-threatening situations in the patient. The patient will become restless, confused, maybe just downright crazy, or they can seize. That's one of the big issues that can occur. So just make sure you're looking out for this as well. You have a great table on page 1400. It's chart 66.5. It's emergency care of the patient during a thyroid storm. So just kind of look that over. It's talking about maintaining that airway, of course, giving any antithyroid drugs as ordered to try to decrease that hyperthyroid state, and then maybe administer the sodium iodine solution. And this is all according to how the provider wants to treat them. So it's all about, you're going to call the provider first, and then these are possibilities of ways that they might treat it. And listed here as well is just treatment for the exophthalmos, the eye and vision problems of Graves' disease. That might be another issue that has to be taken care of related to hyperthyroidism. If they have the photophobia, the sensitivity to light, they perhaps might need to wear dark glasses. Sometimes steroid therapy is given in an attempt to decrease the swelling, so it decreases the damage to the optic nerve. Diuretics can perhaps be given as well to decrease, and it would be low-dose diuretics to decrease the edema, to try to decrease any permanent eye damage. This is just a review of everything that we just talked about post-operative monitoring, so just make sure you understand why each one of these would occur and what you would do to prevent this. Okay, so we're going to move on to hypothyroidism, and this is a deficiency in a thyroid hormone. So the patient is going to have the opposite signs and symptoms. They're going to have signs and symptoms of decreased metabolism. Again, you have a wonderful table or chart on page 1401. It is chart 66.6 on hypothyroidism. So they're going to just be the exact opposite of your hyperthyroidism patient. They're going to be bradycardic. They're going to be tired, slow, report low energy, decreased libido, weight gain, constipation. Skin is going to be a big thing with them. They're going to have thick, brittle nails, dry, coarse hair. decreased hair growth as well. So just kind of make sure you look at those over all those signs and symptoms, and it's really just the opposite of the hyperthyroidism. A lot of it is. Two different reasons for a patient to have hypothyroidism. Primary, they divide it into primary and secondary causes. Primary typically is related to the thyroid gland itself. When there is an issue with the actual thyroid gland, it can be autoimmune. It can be due to a removal of the thyroid gland. If somebody has hyperthyroidism, we take the thyroid gland out, then they automatically need to be treated for hypothyroidism because they no longer have the ability to produce the thyroid hormone. Thyroid cancer is basically if they have to remove the thyroid gland due to thyroid cancer, then that patient would be hypothyroidism as well. Again, hypothyroidism occurs more often in women. Usually it's women who are a little bit older, between 30 and 60 years of age. It does affect women 7 to 10 times more often than men. And they think that there is an association between diabetes and hypothyroidism. Secondary causes is typically related to something outside of the thyroid gland. And this is things like there's something wrong with pituitary gland, because remember we said the pituitary releases something called the thyroid stimulating hormone. So it's important to remember that a pituitary disorder could cause a thyroid disorder as well. And then another reason would be if there's something wrong with the hypothalamus, which again we said is another gland that secretes a thyroid releasing hormone that affects the levels of thyroid hormones. What I want you to think about is in the primary situation, if the thyroid gland itself is not functioning properly, I want you to think about how all this works. So they all kind of work on something called a negative feedback system. So if the pituitary gland senses that there is a low level of thyroid hormone circulating in the body, it will increase the thyroid stimulating hormone levels in order to stimulate the thyroid to make more. But if somebody has a disorder of their thyroid gland where it's not functioning properly, it's not going to be effective. So basically what happens is the pituitary gland keeps sending out this thyroid stimulating hormone, keeps sending it out. So a patient will actually have a high level of TSH and then low level of T3, T4. So a lot of times that's how the diagnosis is made. It's diagnosed by a high level of TSH as opposed to the low levels of T3, T4. So just kind of keep that in mind of how all this works together. Okay, I already brought up these facts. This is just a review of that women get it more often than men, and that there is an association between diabetes and hypothyroidism. There's thought to be an association, and the incidence does increase with age. There's a certain kind of edema that can occur related to hypothyroidism. It's called mixed edema, and that is because it's not fluid like we typically see that causes the edema. It's more of this metabolic breakdown of proteins and sugars that kind of build up inside the cells, causing an increase in mucus and water. So it's a different texture of edema. So it's non-pitting edema that is everywhere, and it occurs especially around the eyes, the hands and feet, and the shoulder blades. They will have a thick tongue, which is pretty indicative of mixed edema. And they actually can get like a husky voice from the edema that can occur around the larynx. There is such a thing as a mixed edema coma that can be a life-threatening situation. And it's very rare, but the mortality rate with this is very high. So it's important to be able to kind of be on the lookout for this in somebody who has mixed edema symptoms already. Basically what it does is it can cause damage to the heart and decrease perfusion to the organs. So just basically kind of be aware of somebody who has mixed edema, that they're at risk for going into a mixed edema coma, which can be life-threatening. Again, it's rare, but it can occur. So just assessing a patient for signs and symptoms of hypothyroidism, again, if it's a woman age 30 to 60, they're complaining of decreased energy, weight gain, change in the texture of their hair, constipation, things like that, then of course they're going to be worked up for thyroid, hypothyroidism. A lot of times anymore, after a patient, especially a woman, reaches the age of 30, with a yearly physical, they'll just go ahead and check their thyroid levels to see if they're showing any signs and symptoms of hypothyroidism, because it's very common. So labs, again, for a patient to determine if a patient has hypothyroidism or not, especially with primary hypothyroidism, the patient is going to have elevated TSH levels and then low levels of T3, T4. Those levels will diagnose a patient with hypothyroidism. I also just kind of want to look at the psychosocial assessment. A lot of times these women will come in with complaints of depression and decreased interest in things, and that's another indication for a provider to check a thyroid level, because sometimes it can be related to their thyroid level, and just by treating that, they can treat those symptoms. So treating a patient with hypothyroidism, of course, you're going to monitor vital signs. Their vital signs are going to be the exact opposite of a patient with hyperthyroidism. They're going to have a decreased blood pressure. They're going to have bradycardia. They can still have some dysrhythmias, which means just an abnormal heartbeat. Just monitor them for signs of that and treat it appropriately. And then the mainstay treatment for hypothyroidism is something called levothyroxine, which is Synthroid. It's an oral pill that can be given to treat it. Basically what happens is they start them out on a low-dose therapy, and then they monitor their levels and gradually increase as indicated by their levels. So here's the big teaching moment for someone who's getting ready to start on levothyroxine. It has to be taken as ordered, exactly as ordered, because as we talked about in hyperthyroidism, if they take too much of this, they can actually kick themselves over to hyperthyroidism and really cause a life-threatening situation. So they need to take it as ordered. And again, like I said, they'll start them out on low dose and then work their way up, because they don't want to just start them on a high dose that could really kick them over to hyperthyroidism and cause them to the opposite of the problems that they already have. Another thing to tell them is that they shouldn't switch around brands of Synthroid. They want to make sure that they're taking the same brand, because sometimes when you switch brands, it can change the dosage a little bit. So it's something that has to be monitored closely for the levels and make sure that they're therapeutic and that we're not giving them too much. We want to give them just the appropriate levels so that their thyroid hormone level is normal. And here's the other teaching thing that occurs with levothyroxine is they have to take it for the rest of their life. This isn't something that they, again, quit taking when they feel better. Can't do that. If you have hypothyroidism, that indicates that your thyroid is not functioning properly, and you need to take this drug for the rest of your life in order to keep your levels up, or you're going to go back into a hypothyroidism. So it's a lifelong treatment. Typically, it's a pretty cheap drug, so it's not too terribly difficult to do, but it's not something that they can just decide, I don't think I want to take this anymore, because they're going to end up being sick again. So they need to take it and maintain treatment with a primary care physician for the rest of their life. So just an emergency situation that could occur if they do decide to stop taking their medication abruptly is that mixed edema coma. And again, it's that edema that can be life-threatening. It's very rare, but it could occur. It can lead to shock, organ damage, and death. So treatment is instituted quickly according to the patient's signs and symptoms, but just it is something that can occur related to an acute illness, surgery, or chemo. So just something to always be on the lookout for if somebody has a hypothyroidism state. There is a chart on page 1403, chart 66-7, about emergency care with a patient in mixed edema coma. And of course, this would all be related to, after you call the provider, they would order possibly some of this, and this would be the fluids. The levothyroxine by IV can be given. Maintain the airway, of course, is always number one on the list. So just make sure you review all of that. The big thing about the patent airway, if you recall when I talked about mixed edema, that's an edema that can occur in the neck and the tongue. So that's why the airway would be an important piece of that care of the nurse. So just quickly talk about hyperparathyroidism and hypoparathyroidism. If you recall, these are just 4 glands that lay on the posterior aspect of the thyroid gland, and their main function is balance of calcium and phosphate levels. So they're pretty important if you think about calcium and how we talked about with osteoporosis and all of that. So it's pretty important that this gland functions properly. Hyperparathyroidism is somewhat rare and typically is in relation to some type of a tumor of the thyroid or the parathyroid area, or trauma. There is a great table on 1406. It's table 66.3 that sort of does a nice little breakout of causes of hyperparathyroidism and hypoparathyroidism. Like I said, the typical cause for hyperparathyroidism is a tumor on that area that will cause excessive levels of calcium and phosphate. Basically what happens here is that there is an increase in the bone resorption, which means breakdown of the bone, and then there's decreased amount of building up of the bone. So there's a deficiency. It's almost like an osteoporosis type situation that's caused by the hyperparathyroidism. So the patient will have very low dense bones, and they'll basically have like almost like an osteoporosis. So they'll be at risk for fractures or brittle bones. So that would be a sign and symptoms. The other thing is if there's a lot of circulating calcium in the serum, in the blood, the patient could be at risk for kidney stones as well. And they also can have signs and symptoms of GI problems. So to diagnose hyperparathyroidism, they're going to have high calcium levels in their blood. So if we took a blood test, their calcium level in their blood would be high. And that's because they're not absorbing it into the bone and using it to make bones. And then remember, calcium and phosphorus are inversely related, so the patient would have high calcium levels and low phosphate levels. So treatment of this is going to be try to lower those calcium levels, and that can be done by a diuretic. Furosemide can actually help increase the excretion of calcium, and then they can do hydration, and basically what the hydration is giving them IV fluids that will help dilute the levels of calcium in the patient. And then you have to look at making sure, their bones are brittle, so you have to make sure that you watch them for falls and make sure they don't have an injury related to the brittle bones. Management of this is typically, especially if it's a tumor in the parathyroid, they're going to have to remove it to get rid of the tumor that's causing this situation. One thing to remember is calcium levels. Calcium affects your heart function, so it can be very, very dangerous to have a high calcium level. So they'll definitely put this patient on continuous cardiac monitoring, and then they want to get those levels as normal as possible before they take someone to surgery, because putting them in a stressful situation when they're already at risk for having a cardiac issue would be very dangerous. So they want to get those calcium levels back to normal and then take them to surgery. The surgical procedure, depending on the patient's situation, they might have to take out all 4 of the parathyroid glands or just maybe one side of them. Nursing care for a patient with a parathyroidectomy is exactly the same as for a thyroidectomy. You got to monitor that airway and monitor for bleeding because you're essentially doing surgery in the same place, and maintain the position of the neck. Make sure you do all that. And then post-operatively, the remaining, if they leave a few of the parathyroid glands in, it may take a few days for these glands to actually function properly. So the exact opposite's going to happen post-operatively. They may go into a state of low calcium now that they don't have this parathyroid gland that's doing all this overproduction of calcium. So you got to make sure that you watch them for their calcium levels post-operatively very, very closely. And it's going to be depending on the orders and the physician, but they typically monitor them every 4 hours until they stabilize their calcium levels. And again, remember that you should know the manifestations of hypocalcemia, which is tingling and twitching in the extremities and face. Trousseau's and Sheffick's signs are indicators of low calcium levels, and those can be found in Chapter 13. Hopefully you recall a few of those signs and symptoms, and we'll talk about those in class. So just real briefly, hypoparathyroidism is the exact opposite of hyper. Different causes for this is if we actually remove the hypoparathyroid, whether it be for a thyroid problem or a parathyroid problem. If we remove it, of course, they're going to have a hypoparathyroid state. Sometimes it just can occur for an autoimmune reason. We're not sure why. So, it's sort of like hypo and hyperthyroidism. There is some causes that are thought to be autoimmune. Actually, a low magnesium state can cause a hypoparathyroidism, and this can be seen in alcoholics and in patients who just have absorption problems. So those are some few causes. It's rare to have hypoparathyroidism, but it is something that could occur in, if somebody's had surgery. Basically, the treatment is going to be focused on monitoring those calcium levels and making sure that they don't have very, very low calcium levels, and then treating them appropriately. This concludes this portion of the Module 7 video presentation.